Hello, and welcome to another episode of In Good Health with McLaren Macomb. I am your host, Aaliyah Flores. Today we will be speaking with neurologist Dr. Aniel Majjhoo about the unique stroke care program at McLaren Macomb. And then we will grab our dogs and head out to Shelby Township for a unique local literacy program. But first we are here with Dr. Arthur Frazier, radiation oncologist, to discuss some recent advancements in cancer care. Hello, Dr. Frazier. How are you doing?
I'm doing great. How are you, Aaliyah?
I'm very well, thank you.
Nice to see you.
Nice to be seen. Thank you so much for coming. And could you share with us a little bit about your background?
Well, actually, historically, I'm from Virginia, and I moved here in 1990. Completed my residency. I worked at the Cancer Institute down in Detroit at Karmanos until about 2004, and then during that time, I was the residency program director for about the last 5 years before I left the Cancer Institute. And then I became the medical director of the Wahby Cancer Center at McLaren Macomb Hospital in 2004. And basically the last 12 years, my practice has mainly been focused on that facility and coordinating the cancer care for patients in Macomb County.
Okay. So you've been treating cancer patients for a lot of years now. Can you just enlighten us to some of the changes that you've seen over the years in cancer care treatment?
Well, I think one of the big areas as a radiation oncologist, and so people might be coming in for 5 or 6 or 7 or 8 weeks of radiation. For some of the cancers that we deal with nowadays, we're using a shorter course of therapy, but we're delivering the maybe equivalent doses of radiation or maybe higher doses of radiation because we're using something called radiosurgery. So the technology kind of started changing between 2000 and 2005, and the computers allowed us to find a way to deliver the radiation more accurately. Some of the cancers that we deal with are in the different parts of the body that are maybe moving. So we have an issue with organ motion. So the prime example would be, like, let's say we have a 90-year-old person who comes in with lung cancer. Mm. They went for a chest x-ray, they had a cough, and then they do a CAT scan, and they've got a tumor. They used to call it a coin lesion, like a tumor the size of a quarter. Mm-hmm. So the standard treatment would be to go in and remove the upper part of the lung, remove that piece of lung. But that could be a very involved surgery for an older person. So we used to treat people with 35 radiation treatments. So we would give them 7,000 units of radiation over about 6 to 7 weeks. But with the advent of radiosurgery, now we're actually giving much higher doses of than that, in the range of 10,000 units of radiation to that tumor in 1 week. So it's typically like 4 or 5 visits, 4 or 5 treatments. And because the radiation is so focused, the risk of toxicity or complications is very low.
So what are the benefits for that patient? And then how does that take a toll, the treatment toll?
So the interesting thing is when you look at like protracted radiation for a patient with lung cancer, 7 weeks of radiation, the success rate was about 30%. Okay. So now with something like stereotactic radiosurgery, it's 1 week of treatment. It's more of a focused form of radiation, so you're staying away from the normal tissues. And the local control rate is between 95 and 97%.
Okay, so more successful, it sounds
So
like.
it's significant improvement. And I think the other area where things have really come along in the last 5 years is like targeted drugs, new drug therapies. Mm-hmm. Historically, chemotherapy, people would say, well, chemotherapy, you're treating the whole body, trying to kill cancer cells, but there maybe was a lot more side effects from that. And so nowadays what's happening is when we diagnose somebody with cancer, we actually test the genetics of the cancer cells to find out what is the most effective drug, or if they carry a gene that we can target with a drug. I think the prime example is melanoma. We have 4 or 5 blockbuster medications that have come out in the last 5 or 6 years for people with melanoma, but you have to test the genes in the melanoma to find out which drug is going to work.
So are those tests pretty accurate?
Oh, they're very accurate because you send the tissue, and they do the genetic testing, and then you know if they have the gene. And if they have the gene, then you have it's like an antibody therapy that's going to target those cancer cells. And by doing that, you're going to avoid a lot of side effects because you're only really going after the cancer cells. You're not going to have a lot of systemic side effects that people would think of when they think of those kind of treatments.
So with Karmanos being new to McLaren Macomb, what type of resources does Karmanos offer for McLaren Macomb?
So McLaren Macomb, the Ted B. Wahby Cancer Center, this was a vision that goes back maybe 15, 20 years. And when I came here in 2004, the hospital administration said, well, our goal is to have the #1 cancer center in Macomb County. And I think we have moved to that position. We have in 2007, we opened the cancer center, which is behind the hospital. And then just in the last couple of weeks, the second phase was completed, which was about a $20 million construction project. And now with the affiliation with Karmanos, what's happening is not only is our technology phenomenal, we are adding some additional personnel. In fact, next month we will have we've been asking for genetic counseling for the last couple of years, and so we'll have genetic counseling starting in October, which will be wonderful because a lot of the patients that we see, they come in and they'll say, well, their mom had cancer, their dad had cancer, their uncle had cancer, some of their children have had cancer, and there's something else going on rather than, just bad luck. And so we need genetic counseling. We diagnose people with genetic problems with blood tests and so forth. I think having a genetic counselor on site is a major advantage. And other than that, it's pretty phenomenal if you see what's happening at the cancer center. We have what are called multidisciplinary tumor boards. We have tumor boards for breast cancer, gastrointestinal cancer, head and neck cancer, cancers like what we call genitourinary, like bladder cancer, prostate cancer. We have gynecologic oncology. Dr. Michael Hicks is our gynecologic oncologist, and we have our G1 oncology tumor board. But it's very coordinated. We have several other people that are involved because we have social workers on site, which is wonderful because, people under stress.
Right.
Society is already super stressful, and then you add health problems and family problems.
You need someone to talk to. So
we have phenomenal social work support, and then we just in the last 2 months, we have a dietitian on site. So we have dietitians, we have genetic counseling, social work, and it's all right there in the center. So it's just amazing.
So with that being said, in your opinion, what does the future of advancements in cancer look like?
So I think for the radiation therapy, radiation oncology, certainly more focused radiation, but there are other big areas that are very important. I think a lot of the future will be various forms of drug therapy, targeted drugs, monoclonal antibody therapies, and then vaccines. So it's phenomenal, I think, where the future is going with oncology.
Are there certain cancers you're seeing more of recently?
Well, one of the things about McLaren Macomb Hospital, they have been very aggressive in the right kind of technology. We have some of the best mammography imaging equipment in the state of Michigan. One of our biggest growth areas has been breast cancer. Breast cancer is certainly been increasing as far as the diagnosis, but it's early stage patients because they come in for their imaging. We find the problem before it becomes a serious issue. Besides that, certainly the best time to be in oncology because of all the technology, the focused forms of treatment that we can deliver, the safer drugs, safer treatments, and it's really a very coordinated program, which makes it wonderful for the patients. We have a lot of people who come in and they're completely stressed out. We've got social work. We've got a lot of people helping to get these patients through the program.
You have been very insightful today, and thank you
thank you.
so much for all of the great information for our viewers. Thank you so much, and have a wonderful day.
Thank you, Aaliyah.
Okay, thank you,
Appreciate
Dr. Frazier.
Thanks a lot.
Thank you.
To learn more about cancer care at McLaren Macomb, visit mclaren.org/Macomb Cancer.
And now let's head out to Shelby Township.
Well, today we had Run, Walk, and Wag to Read. It was a fundraiser benefiting Macomb Literacy Partners. We recruit and train volunteer tutors to teach adults how to read or to teach them English as a second language. About 13% of the people in Macomb County read below a 4th grade level, and that only includes adults. So you know somebody who can't read very well. Everybody does. And they hide it very well, but it has a real cost on their lives, their ability to parent, their ability to earn money for their families. Well, Macomb Literacy Partners started in 1984, and we have been helping adults learn to read free of charge or learn English as a second language for 32 or 33 years now. And we've helped about 5,600 people in Macomb County. From a health benefit, people that can't read have health that is not that good because they don't have the information available to them. They can't understand discharge papers from the hospital, prescription bottles. So it's really important to be able to read even for a health benefit. It's really healthy to be outside, to be walking or running, and it's proven that pets also help with your stress level and with high blood pressure and all that sort of thing. So it's really a good healthy event. And we've had about 75 participants. It's the first time we've ever done it.
Yeah.
To learn more about how you can help, visit MacombLiteracy.org.
Hello and welcome, Dr. Maju. How are you doing today?
I'm great, thank you.
Thank you. Well, thank you for coming to speak with us today. And could you share a little bit about your background with us?
Well, my name's Dr. Aniel Maju. I'm the director of neurosciences for McLaren Health. I also function as the director of stroke and interventional neurology at McLaren Macomb Hospital. Okay. I am a board certified neurologist, and then I also did fellowship training in stroke or vascular neurology. I'm also board certified in neurocritical care, and I did a 2-year fellowship in interventional neurology, which is endovascular surgical neuroradiology, which is special surgical treatments for cerebrovascular diseases, stroke, and aneurysms.
Oh, wow. Nice. Very nice background. So for those who don't know, could you just share with us a little bit about what a stroke is and the signs? Sure.
A stroke typically is interrupted blood flow, usually by a clot that's blocking the blood flow to a part of the brain. Okay. And when this happens, there's the essential nutrients and oxygen is not getting to that part of the brain, okay. And you develop neurologic signs. So it may be something simple as facial weakness or drooping of the face, or it could be loss or blacking out of one vision in your eyes, or it could be something more severe as weakness in a limb or in the entire side of the body, leaving you paralyzed.
Okay. Now, is there an acronym for that? Is it called FAST?
Yeah, absolutely. FAST is something that was developed by physicians actually in the UK originally, and it's been adapted for the quick assessment of stroke victims.
Okay.
The acronym FAST stands for FACE, is for the sudden onset of facial weakness. So you can look in the mirror and see if your face looks droopy on one side or the other. A stands for the sudden onset of arm weakness. So if you were to raise your arms in front of you like this, you'll start to see drooping, or it might just be totally paralyzed. And then the S is for a speech disturbance. It's whether you can't produce the right words, or can't comprehend the right words, or just slurring of the speech. The T stands for time, because time is of essence. You need to get to the ER immediately if you develop those type of symptoms, and for appropriate treatments for stroke.
Okay. Well, thank you for sharing that information.
No problem.
So, what makes the McLaren Stroke program so unique?
So the McLaren Stroke Network is a coalition of all the McLaren hospitals, from Petoskey all the way to Pontiac, through telemedicine, the interventional neurologists, the ones who actually perform the surgeries for stroke, are taking primary stroke call. And then we're like one of the only centers in all the country, and definitely the only center in Michigan that does that, where the interventional neurologists are taking the primary stroke call. What that means is, via telemedicine, where these two-way cameras we have set up in the hospitals, we can actually examine the patients at all those centers, and make the help with reviewing the CAT scans in the labs, and counsel the patients and their families. And with the ER physicians at those facilities, we can make the timely decisions for IV TPA, which is the clot busting medication, as well as making decisions on whether they need something called a thrombectomy, which is removing the clot from the brain, those surgeries I was talking about. So McLaren Macomb itself receives transfers from McLaren Port Huron and McLaren Oakland and Pontiac. So that is part of the network here that we have set up.
Sounds like very innovative technology.
Oh, definitely. We have a lot of experience with this technology. The McLaren Stroke Network started about a year ago. In doing so, we've seen the door to needle times of giving IVT has been reduced across the entire health system. We've seen that we've performed thrombectomies. We offered the surgery itself more times than we ever did in the past. We actually did the most thrombectomies in all of Michigan last year. And more importantly, we've seen very good functional outcomes of these patients. We're seeing patients that were having large vessel occlusions who would have had about a 50 to 7% chance of ending up in a nursing home or dying walking out of the hospital. So we're very proud of what we have accomplished over the last year, and we definitely are going to grow it.
So what does the patient's follow-up consist of?
Usually when we follow up with these patients, if they definitely have a thrombectomy, they definitely follow up with the interventional neurologist.
Okay.
If they just get IV TPA, some of them follow up with us, but we do have excellent general neurologists as well that we work with, that they can follow up with. We check on them to see whether they're getting the appropriate rehabilitation needs, speech therapy. They're doing everything for preventative measures to prevent another stroke from happening, because once you already had a stroke, their chances of having another one is increased.
So I know we talked a little bit about some of the warning signs, but could you just go in a little bit more in depth about some of the warning signs and the risk factors involved with a stroke?
Some of the risk factors for stroke that you should be aware about is high blood pressure, hypertension. If your normal blood pressure is supposed to be less than 120/80. If you have consistent blood pressures over 140/90, then you need to go see your primary care physician. You may need medications, you may need to be making some changes. The number 2 cause of stroke, or risk factor for stroke, is smoking cigarettes, whether it be firsthand or secondhand. So that definitely is something that needs, it's a modifiable risk factor.
Right.
Number 3 would be diabetes.
Okay.
Weight loss, and going to see your physicians for blood sugar control would help. 4 would be high cholesterol, so getting that in control. Number 5 ties into those first a few. It's inactivity and obesity, and so that can be addressed as well. And having prior history of transient ischemic attack, a TIA or a mini stroke, is a risk factor for another stroke. Non-modifiable risk factors are things like age. So the older you get, the higher is your risk of having a stroke.
Okay.
Men have men have strokes more than women. So, you know, that's something where that's an age group that we've actually made a significant impact on in the last year, where we've treated a lot of women with those stroke surgeries that we were talking about, the thrombectomies, and we're seeing very good results. So those women are living longer now, and with less disability, because stroke is the #1 cause of disability in our country.
Right.
It's affecting about 800,000 people per year.
Okay.
Every 40 seconds, someone has a stroke in our country, and every 4 minutes, someone dies from a stroke in our country.
Okay.
In addition to the non-modifiable risk factors, ethnicity, you know, is something that we can't change, but at the same time, you know, puts us at an increased risk. Certain ethnicities, for example, African Americans and Hispanics have strokes more often than Caucasians.
If you could also just enlighten us a little bit about the advancement in stroke therapy that you are using.
Okay, I'd be happy to do so. So, you know, we touch on interventional neurologists and the minimally invasive surgeries. Well, so basically up until 1995 in the therapy of stroke, there was just this clot busting medication that can be given through the IV. It was called TPA. We still have that. You know, it can be only given to people within the first 3 hours of their symptom onset. Some patients up to 4.5 hours. You know, that's what we've had for the last 20 years. But now, in addition to that, we have these minimally invasive surgeries where, similar to the cardiologist, we make a small incision in the groin, bring a catheter and tunnel it up through the aorta up into the brain, and we actually physically remove the clots that are causing the stroke symptoms. That's something called a thrombectomy. In 2015, there were 4 randomized controlled trials and 3 registries, so 7 trials total that were overwhelmingly positive for these therapies and proved that this is the best standard of care for stroke victims. So that's what led to the changing of the guidelines for stroke care in America. And McLaren was at the forefront of that, and we actually adapted all of those changes in our protocols, and that's how we actually have developed our entire network around that philosophy of treatment.
Oh, wow. Well, thank you so much for educating our viewers.
Thank you for having me.
Okay, thank you.
All right, bye-bye.
Bye-bye.
For more on warning signs of stroke, visit mclaren.org/Macomb Stroke.
Thank you for joining us on this episode of In Good Health with McLaren Macomb. We'll see you next time.
To view this episode again, visit mclaren.org/Macomb blog.